Um, uh, this presentation is being provided as part of the Maryland Addiction Consultation Service, which is a statewide service associated with that provides both warm line consultation for providers with questions about specific clinical issues, as well as general educational events like this one. So we are going to be talking today about methamphetamine and other non-medicinal stimulants in Maryland. I think the email that went out said non-medical stimulants, but specifically talking about stimulants that are not prescribed by doctors today. So an outline of the talk for today is to talk about the epidemiology of non-medicinal amphetamine type stimulant use in the US and Maryland. So we're going to have a brief detour to global health, manifestations and common comorbidities of stimulant use disorder, describe the evidence base for stimulant use disorder treatments, including psychosocial interventions and medications, and hear from an individual who's in recovery from methamphetamine use disorder as well. And thanks to those of you who joined on time today. So although I said I was going to talk about methamphetamine use in Maryland and the US, I'll actually start with an even bigger picture with data from the UN 2020 World Drug Report. That's the UN Office on Drugs and Crime. As we can probably many of us can recognize, it's not a foregone conclusion to have drugs and crime put together in an office. Might actually be better off if we separated drugs from crime and address this as a medical problem or as a social problem. Regardless of how we define it, amphetamine type stimulants are a big problem worldwide, or widely used worldwide. They're actually the third most commonly used drug class after cannabis and opioids, having overtaken cocaine some years ago. I'll talk about kind of some specifics about the molecules, but just to kind of whet our appetite for thinking about how amphetamine type stimulants may manifest here in Maryland. Describe a patient that I saw, actually I've been seeing pretty much weekly recently, who I'm seeing via telemedicine in Caroline County on the Eastern Shore. He has a history of methamphetamine and opioid use disorders, bipolar disorder, and hip osteoarthritis, who's done quite well in terms of his opioid use disorder treatment with buprenorphine, and was prescribed a novel second-generation antipsychotic by an outside psychiatrist. He seemed to be doing okay on that. But over the past few months, I've started to have urine toxicology that's positive for methamphetamine when I'm doing the routine urine toxicology to follow him for his opioid use disorder. For a few months, he said he wasn't using. He said he was quite surprised, or expressed a great deal of surprise that he might have methamphetamine in his urine. Then he acknowledged that he'd been spending some time with some biker friends up in Dover, Delaware. That they make a lot of meth in their trailer, and so that whole place must have just been contaminated with methamphetamine. So maybe kind of got into him passively, and then kind of most recently with further conversations, non-judgmental engagement, he endorsed relapse to meth, not opioids actually, thankfully, when he was triggered by seeing others using what he described as crank and dope in a trailer he wandered in to while bored at a bonfire. So I would highlight a few points about this case, just again to set some framing for the talk. The fact that I was seeing Donnie in a rural setting, not his real name, obviously. I was seeing Donnie in a rural setting that in Maryland, it was existed in combination with an opioid use disorder, thankfully in Donnie's case, well controlled, and that for him, boredom was a trigger, as well as being around the drug. I feel like these are things that we commonly see in people that have that are living with stimulant use disorder, cocaine use disorder, and opioid use disorder. So these are some molecules or pictures of molecules. This is the kind of things that make doctors feel happy they did organic chemistry. We can pat ourselves on the back. This is amphetamine and methamphetamine. As you can see, methamphetamine this is the archetypal amphetamine drug, and then they, if you stick an extra an extra carbon group here on the end of it, it makes it more lipophilic, allows crossing the blood-brain barrier faster, allows for more for a stronger psychoactive effect. Keep your eye on the screen and watch as we look at some other molecules. You can see that actually there's a fairly similar structure with the cathinone type stimulants, which are derived from the East African plant khat. Now these are ketones for those of us who did organic chemistry. Again, we can pat ourselves on the back, but similar structure. And interestingly enough, bupropion has a similar structure as well, a commonly prescribed antidepressant, which can be pertinent when we're thinking about toxicology testing. Mechanism of action of stimulants is probably similar across the stimulant class. Probably shares some similarities with cathinone type stimulants and also with ecstasy as well, or MDMA. Basically, it fundamentally causes, through a variety of actions, causes increased synaptic dopamine, which in parts of the brain associated with reward are associated with a feeling of satisfaction or euphoria, feeling high. In other parts of the neuroendocrine system might be associated with increased release of bioactive amines like epinephrine and norepinephrine, leading to the characteristic physical effects of stimulants like elevated heart rate, high blood pressure, pupillary dilation, and the like. This is use of methamphetamine as evidenced by overdose rates has been increasing over the past couple of decades. There's a lot of lines on this graph that you can see. Synthetic opioids are obviously driving the terrible situation with overdoses countrywide. But you can see as well that the blue line here, the psychostimulants with abuse potential, that line has really increased quite steeply of late, along with cocaine, actually. I mentioned at the beginning of the talk that methamphetamine and opioids are frequently used together. And so as we see kind of a skyrocketing of opioid overdose rates, we might ask ourselves whether the increase in methamphetamine overdose rates is just due to its association with the co-administration with opiates. You can actually see that as of 2019. Unfortunately, psychostimulants in combination with synthetic opioids other than methadone, that rate has been increasing significantly, but that we can see that psychostimulants without any opioids, these are basically autopsy data, death from psychostimulants, including amphetamine type stimulants like methamphetamine, has been increasing. So this line here that's going up is a sign that people are having significant physical complications from their methamphetamine use. It's actually harder to kind of track down who is suffering negative physical consequences from methamphetamines compared to opioids, because unlike opioids, obviously have a very, very rapid overdose effect. So someone can use a little bit too much by accident and suddenly find themselves dead. Most of the physical consequences of methamphetamine happen subacutely or chronically, so and are related to the side effects on the heart and on the cardiovascular system in general. So we're probably undercounting the morbidity and mortality related to methamphetamine use. There's also been a substantial increase in the past decade in the percentage of people that are seeking treatment for heroin use disorder who also report methamphetamine use, up from only 2% in 20 years ago to 12.5% most recently. This is a little bit of a complicated slide here, but you can see that methamphetamine use, it's funny they put it all together here, but methamphetamine injection, methamphetamine use of people, of adults who reported to the National Survey of Drug Use and Health over this 3-year period, of people who reported methamphetamine use, about a little less than half reported that they used over 200 days out of the year. Almost 60% reported that they met criteria for methamphetamine use disorder. A minority had received substance use disorder treatment, and about 22% reported having injected methamphetamine. So this is 22% out of the 100% of people who are using methamphetamine reported injecting it. As you can see, it was very frequently co-administered with cannabis and alcohol. I'm surprised that this nicotine dependence number was so low. I'm actually wondering if it was represents a problem with the data, and that it was associated with other mental health problems. Methamphetamine morbidity and mortality disproportionately affects individuals from native backgrounds here in the U.S. And disproportionately affects people who are white. As you can see, American Indian and Alaska Natives, the rate of the 20% of U.S. overdose death involve Native American and Alaska Natives, and 10% of white overdose deaths. Very, very high. This is pretty remarkable sitting where we are here in Maryland. So this is an animated slide that you can see showing basically methamphetamine overdose rate per population unit of 100,000 people. So between 2011 and 2018, this is a slide from the Rockefeller Institute, we can see that overdose rates are rising in the West and kind of moving across the country towards the Middle West, showing up in Appalachia as well. I think this should make us all very concerned that rates are going to start to increase here in Maryland. There's been a 6-fold increase in positive methamphetamine tests for people seeking drug treatment since 2013. And according to the 2018 National Survey on Drug Use and Health, about twice as many people reported using methamphetamine as reported using heroin. So this is, although here in Maryland we're largely spared most of the really negative effects of the national methamphetamine epidemic. I feel like it's pretty clear here that it's coming, and you can see it right over the border here in West Virginia. As I mentioned, vulnerable populations include rural whites, which is spreading east. It's getting mixed more with opioids, and getting stronger and more available with kind of industrial P2P based manufacture. That refers to the way that the methamphetamine is being manufactured. As I mentioned, really significantly adversely affects Native American and Hawaiian communities. Yet another group that is vulnerable to the negative effects of methamphetamine use, particularly disproportionately affected is men who have sex with men. According to some studies, reports use at up to 25 to 45% the rate of the general population. That statistic was from one study from men who have sex with men in the Miami area. But the general consensus is that nationwide men who have sex with men are more likely than others to use methamphetamine, sometimes in combination frequently in combination with sexual activity. People have decreased inhibitions, more energy, and are kind of at increased risk of HIV transmission, hepatitis A, hepatitis B transmission as well as other STIs due to chemsex. In Maryland, as I mentioned, we were kind of for a long time spared the same impacts that rural populations in other states were experiencing, and states in the West. In 2002, the state said that methamphetamine use is limited in Maryland. And in 1999, there actually had been no methamphetamine-related admissions to publicly funded facilities across the whole state. In 2020, the latest period for which we have data available, there were actually 52 meth-related fatalities in the first 9 months of the year. So that's a pretty significant change over the couple of decades. In Maryland, most deaths are related to the co-administration of opioids. If the national model is any guide, we're probably going to see some more increases in deaths related to people who are using methamphetamine without opioids. People call it, in this state, people call it ice and glass. Old timers tend to call it crank. Here in Baltimore, cocaine is really still the dominant stimulant, which people call girl here, contrasting it with boy, which is how opioids are generally referred to. Traditionally, there's been limited other stimulant use, with a couple of exceptions, which are kind of increasing over time. For years, people, especially younger people, have talked about being able to access what they call e-pills, which are stimulants typically sold in tablet forms. E-pills theoretically refers to them being ecstasy, so maybe MDMA. There's probably not a super reliable quality control when it comes to the clandestine chemists who are making it, but it probably is some combination of MDMA, amphetamines, other phenethylamine compounds, amphetamine-type stimulant compounds. Over the past few years, we're also seeing an increase in Molly here in Baltimore. Now, Molly was, I think, initially made its the nomenclature Molly made its emerged, probably close to 20 years ago now, and was specifically referring to supposedly molecular ecstasy, so pure MDMA. Here in Baltimore, really no one who uses Molly thinks that it's pure MDMA. People tend to acknowledge that it's probably a combination of methamphetamine and/or synthetic cathinones, typically sold in little bullets, so small vials like perfume vials, or what they call trash cans, which are small, almost like trash can shaped little plastic vials with a pop top. Molly is typically smoked or injected here in Baltimore. I actually just saw Daryl outside in the hallway, again, not his real name. I'm seeing him here in an integrated opioid use disorder and primary care and infectious disease practice here. He has a history of intravenous drug use, cocaine and opioids, on 120 milligrams a day of methadone. Urine is still positive for fentanyl, methamphetamine, and methadone, and he says that he's been using dope and Molly IV. He has terrible problems with what he describes as scabies. He's been treated with the Cadillac of scabies treatment, so oral ivermectin and topical permethrin therapy. He has kind of excoriated areas of his skin, weeping skin ulcerations on his extremities and chest, none on his back, and nothing in the between his fingers, as you would expect for someone who had a scabies infestation. He tells me that everyone who uses these research chemicals, referring to the Molly that gets in trash can form, everyone who uses these research chemicals gets these bugs. I've seen them stick their heads out at night. And actually today, as I walked by him in the hallway on the way to give this talk, he actually showed me a video that he had taken on his phone, something he said he had taken a credit card and was scratching his head with the credit card and scraped off a bug from his head onto the tabletop and had filmed it. And I will say that the video quality was not very good, unfortunately. I wasn't able to identify any known parasite, any known infesting insect. Did look like there was a little dot wriggling around on the table, but this is obviously a source of great, it's really disturbing for this guy who's feeling like he has a constant infestation of insects. So this is kind of this parasitosis is one of the characteristic psychiatric sequelae of stimulant use, and can be associated, in addition to this feeling of formication, which is the feeling that you have ants crawling under your skin, be associated with really prominent psychotic symptoms. Up to one study suggesting that up to 40% of methamphetamine users experience psychotic symptoms and syndromes. Obviously, as we mentioned, infectious diseases related to intravenous drug use and chemsex, hypertensive diseases, heart disease, including methamphetamine-associated cardiomyopathy, which can be a very, very morbid condition leading to dilated cardiomyopathy, really even in young users, and malnutrition just from self-neglect. I didn't put on this slide problems with teeth, but as with many drugs that people tend to like to use, it can cause dry mouth, and so the dry mouth and decreased salivary flow, and then also poor oral hygiene because of changing priorities can lead to pretty significant problems with teeth. And so, tooth problems are kind of a pretty well-known effect of both opiate and stimulant use. So, word about toxicology testing for those of you who are seeing individuals who you are evaluating or treating for amphetamine-type stimulant use disorders. Most stimulants have a 2 to 4 day urine detection window. Methamphetamine is metabolized to amphetamine, so both can be present in urine after methamphetamine use. There are a bunch of prescription medicines that are also metabolized to methamphetamine or methamphetamine and amphetamine, including selegiline, femproprazole, and bensphetamine. These are weight loss drugs. Selegiline is a Parkinson's and depression medication, as you probably know. And so someone who uses methamphetamine is going to have a urine toxicology test that's positive, typically for methamphetamine and amphetamine. Ecstasy, or I try to say it, 3,4-methylene dioxymethamphetamine is metabolized to MDA, which only sometimes cross-reacts with the amphetamine immunoassay. So what that would mean is that if you're someone who's using ecstasy, who says they've been using ecstasy, may not come back positive for amphetamines. There's a lot of other ELISA cross-reactivity with non-amphetamine type stimulants, mantidine, bupropion, chloroquine, chlorpromazine, dizipramine, and other TCAs, ephedrine, labetalol, procainamide, phentermine. I mean, the list is pretty long. You can Google it. Trazodone and ranitidine, commonly prescribed, medications in the primary care setting, can sometimes cause a false positive amphetamine test. Virtually nothing causes a false positive GCMS test. So if there's any question, if this is a question related to, legal questions, or it's really going to change management, if someone has a amphetamine test that they say can't be the case because they're not using, then you would send that for a confirmatory GCMS test. Cathinones typically are not, don't cause a positive result on the amphetamine test. Just one interesting kind of wrinkle is that the Vicks vapor inhaler is one enantiomer of methamphetamine, L-methamphetamine, whereas the kind of available illicit methamphetamine is typically a racemic mixture of P and L, and pharmacologic digoxin, which is rarely prescribed for ADHD, is just the D enantiomer. So if someone uses a lot of Vicks vapor inhaler, they could potentially have an incorrect GCMS. So you would probably want to recommend to someone who's being tested for methamphetamine that they choose a different inhaler for. There's lots of good options other than the Vicks vapor inhaler. One other thing is that amphetamine is not metabolized to methamphetamine. So someone who's getting a prescription for Adderall should not have a urine toxicology test that's positive for amphetamine. Diagnosis of stimulant use disorder is the same as diagnosis of other substance use disorders, with mild use disorder being diagnosed as with any two to three of these 11 criteria. moderate, I think it's 4 to 7, and then severe, more than 7 of the 11 criteria. So in terms of treatments of stimulant use disorder, psychosocial interventions are really the mainstay of treatment. The matrix IOP model is the archetype, which I'll talk about a little bit more in a moment, or maybe I talk about it now, actually. Matrix is the name of a substance use disorder treatment facility in California. Probably should have like a little registered trademark sign next to it, but it's an outpatient intervention based on, they say, cognitive principles, and it incorporates individual, group, and family therapies, regular drug testing weekly, actually, during the stabilization phase, and required participation in a 12-step program. Contingency management, essentially setting up people's rewards in their environments to help them not use, to reward them for not using. Also help support people in their recovery from stimulant use disorder and cocaine use disorder. And comprehensive case management, helping people address social determinants of health like housing, food, transportation, vocational needs, also seems to help with the sequelae of stimulant use disorder. There is some evidence for anticonvulsants, extended release stimulants, prescription stimulants, and aldehyde dehydrogenase inhibitors, particularly disulfiram. I'll talk about that a little bit more, but really the psychosocial interventions are the mainstay of treatment. To talk a little bit more about the matrix IOP model, there's a few components to the IOP. There's the early recovery skills group, the message of which, this is from tip 52, I think. It's one of the SAMHSA tips. If you Google SAMHSA tip matrix model, you'll see this actually a pretty good handbook on how to deliver matrix IOP services. But basically, early recovery skills group emphasizes that people can change their behavior in ways that will make it easier to stay abstinent. And you get some strategies and practice opportunities to do that in the groups. And really tries to get across the point that 12-step or mutual help groups are a mainstay of treatment. It's interesting because the evidence for 12-step groups alone for substance use disorders in general is kind of lacking. But in this evidence-based matrix IOP model, there's actually strong evidence for this as a collective intervention or as a whole intervention. After the stabilization phase, people engage with a relapse prevention group, which kind of the main themes of which are that relapse is not a random event, that people can identify the process through which they relapse and kind of follows predictable patterns, oftentimes associated with exposure to people, places, and things. That signs of impending relapse can be identified by staff members and clients, and there's a variety of kind of example session topics. One thing that's neat about matrix model is that it kind of also makes space and time for family support and education, consistent with the concept of network therapy. Another evidence-based intervention which suggests that actually having family, trusted friends involved in recovery actually helps in keeping individuals accountable to themselves and to their own self-identified treatment goals. Continuing care kind of keeps happening through a 12-step group and then weekly toxicology testing at a minimum. Individual counseling actually is not super prioritized in the matrix IOP model, although it's kind of typically has a minimum of at least 3 manualized sessions. So in terms of medications for stimulant use disorder, there's nowhere near the evidence base for medications as there is for those used for opioids. It's not clear, although it's plausible, that interventions tested for cocaine would work for amphetamine-type stimulants, including methamphetamine. One kind of recent study combined topiramate titrated to 200 milligrams a day, extended release mixed amphetamine salts at 60 milligrams a day. So that's Adderall XR plus topiramate. Showed promise for cocaine. It wasn't tested for methamphetamine. Um, and but it's plausible to think, as Mark Fishman mentioned at the recent Maryland Society of Addiction Medicine meeting, it's plausible to think that this would be helpful for stimulant use disorder as well. Bupropion and mirtazapine have also been studied. The results from those studies have been pretty underwhelming. Mirtazapine decreased use in risky chemsex in one small study of men who have sex with men. Hard to know if that's related to just decreasing people's libido in general, or their ability to have an erection, or a direct effect on methamphetamine. Maybe if you can't have chemsex, if you can't have sex, it makes using methamphetamine to have chemsex seem less appealing. Doesn't seem like a great intervention. So really want to highlight the psychosocial interventions and making sure that in the addiction treatment or primary care setting, we're addressing the physical comorbidities and psychiatric comorbidities that frequently go hand in hand with long-term stimulant use. So that would include making sure that people are appropriately screened for sexually transmitted infections and bloodborne infections like HIV, hepatitis B, hepatitis C, and making sure that you're addressing and treating hypertension and other vascular diseases that resulted. So, in summary of the kind of PowerPoint section of this talk, again, psychosocial interventions, including manualized counseling and contingency management, care and family support, help quite a bit. Medications are tempting to use because we as doctors like to prescribe things, but the evidence base is shaky. So certainly that would be a conversation you would want to have with your patient, with your colleagues, want to talk about the risks, the potential risks and the potential benefits of the medications that we're using. I'll say in this opioid use disorder specialty treatment setting, I usually start with topiramate if someone is very motivated, but also increase the frequency of their medical and counseling interventions to try to kind of work hand in hand with that medical intervention. I've tried extended release mixed amphetamine salts or Adderall XR for patients who are using both amphetamines and cocaine. But I really kind of ask people to leave regular toxicology tests so that I can ensure that they're adherent to the treatment that we're prescribing, and that has actually been very challenging for people. So I haven't had much luck with medicines for stimulants or cocaine. And if it's not already present in your community here in Maryland, then I'm worried and sorry to say that I think that it may be here soon. So I wanted to take a moment. I wonder if we can, let me stop sharing here. I invited my friend Bryce today to check in with us. I wonder, is it possible to split the screen or to make Bryce and me the main people on the screen, Bridget? I've tried this before.
I know that we can move individual to this stage at once. I don't know if we can do that with two.
Can we make it can we just have everyone visible on the screen?
Since it is a WebEx event, only the panelists are visible.
Then I guess we should probably, and we can't make two panelists visible simultaneously. Is that what we're thinking?
I don't see a way to do that. I don't know if Julia or Silas knows.
No, so there's a way to make you both visible at the same time, but it will bounce back and forth when you both speak.
That works. Sounds good.
Great.
Bryce, are you ready for your close-up?
Yes, I can. Can you hear me?
I can hear you, yeah.
Okay. I can barely hear. I have a slight problem with hearing you without you breaking up.
Yeah, I wonder, you're breaking up just a little bit. I wonder, you're having a hard time hearing me or the other presenters?
Anybody who's speaking seems to be breaking up.
Yeah. I wonder if there's an internet issue.
Can everybody hear me?
I think I can hear you. Yes.
My name is Bryce.
So let me I'm going to pull up the questions that we had discussed here, Bryce. I have a screen above the screen I'm looking at you at. So I'm not looking to the heavens. Here I'm looking at the screen that's above your.
Whatever gets you through the night.
Let's see if I can hear you now.
Let me see if I can. Hold on. Switch my Bluetooth.
Switching to Bluetooth.
Everybody hear me better now?
That is much better.
Okay. 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 Aaron, what do you want to ask me?
So, do you want to talk a little bit about kind of how you first started using methamphetamines and what that was like, both positive and negative?
Hey, hold on a second, real quick. I think my phone. Bear with me. The cellular load. I hate this shit. Let's see. Okay, I'm just going to turn it on high data mode here. Data mode. My bad. Sorry about this, guys. Okay. Let's see if that works any better. Okay. Yeah, how I felt about using oh, by the way, I wanted to say that I really like the word formication. That's a really creative use of that word. I thought that was a great word to use to describe the feeling of ants crawling under your skin. But I wanted to talk a little bit about my using methamphetamine. I am a multidisciplinary drug user. I have a equal opportunity drug user. I'm neither a medical professional nor even an amateur enthusiast of the process that lies behind drug use. I only know from using drugs continuously for 20 years at what people would consider ritual overdose patterns. It's something I'm not proud of. It's just something I fell into because of various things that happened in my life. I blame no other person except myself for it. I love using stimulants because early in life, my personal experience is that I spent a great deal of time in my teens in a state psychiatric institution. And I was given many different courses of many different types of antipsychotic drugs and antidepressants, which when I was released from the institution and no longer made to use the medications, gave me tardive dyskinesia and a tremor and a ringing noise in my head that's distinct from tinnitus, which I also get on occasion. So, wondering what I could do to alleviate those symptoms, which were profound and severe, I happened upon stimulants, methamphetamine, which was a wonder drug because it basically it didn't make me not feel the symptoms; it made me not give a shit. So, which is the same I feel about heroin. Heroin is a great drug for operating on yourself while you're conscious. No other drug in the world can do that. Heroin is a very powerful analgesic pain reliever. Aspirin doesn't cut it. The problem with things like heroin is that if you don't have any large pain to manage, it manufactures some for you. That's the main problem with heroin. Stimulants, I found, enabled me to pursue a life of crime with greater ease and with less intrusion from conscience or the opinions of other people or what they mattered to me. Which is I realize is almost a sociopathic thing to say, but I'm a pragmatist at the base root of all things. That's how stimulants made me feel. For about 15 years until I started to get old, and they started to wear on my health a little bit because I would not sleep for 4 and 5 days at a time, which is deleterious thing to do to your body. I probably would have kept on this way till I died if I had not been forced to discontinue the use of stimulants and opioids by the state. I was a career criminal, so it was inevitable that I was caught by the law at some point and made to answer to the law for my misdeeds. And they realized I had a substance use disorder, so I was offered drug treatment programs. The first one I entered was the Salvation Army, which I can't, in good conscience, recommend to anybody because it is a slave mill that is kept in business by the state because the state loves supplying free labor of miscreants and undesirables that they're going to get rid of and not have to put in jail because in California the jails are full. I lasted about a month there. I was initially pretty gung ho about not doing drugs because when you're in jail for a week and you get to sleep and eat a couple of regular meals, even if they're not very tasty, you start to realize, hey man, there's something different besides ritual drug use and committing crimes. So all that wears away after a while if you realize that you're being used as slave labor. And one of the things that I as a humorous aside, my Quran was confiscated at the door at the Salvation Army. I said, isn't that a violation of my First Amendment rights? It's like, well, no, you don't have First Amendment rights. You're a prisoner here. You're a beneficiary. So I said, you can believe in any God you want as long as it's our Lord and Savior Jesus Christ. So that was their basic attitude. I didn't last long there. I quickly got violent against somebody who was trying to assault me, and I was summarily thrown out of the program. I would have been thrown back in jail if I had not entered another one. So I entered another program called Cura, an attack therapy, cognitive behavioral therapy treatment program in Fremont, California. I stayed there for 6 months. I completed the program by faking my way through it because at that point, all I wanted to do was, complete my sentence and my obligation to the court. And it was a co-educational program. There were about 40 people there. It was a comfortable setting, except for when the staff would force you to do things like your own grave with a spoon, or take a bunch of rocks from one place to another and then back again. Pointless labor that's meant to make you think about what's going on with you. To me, a therapy only works for people who it doesn't. I can't say how it really works for people. It just all it does is reinforce what a piece of shit you think you are. You're already being made to think in a pressure cooker without being able to work or read material that you want to read. You're forced to write a life story that you don't probably even want to know for yourself. Most people who do drugs, as far as I'm aware, they're not really interested in their life story. They want to forget about their life story because their life story is fucking horrible. Pardon my language. So I got through that program, 6 months of it, and I immediately relapsed. That was I don't know, 8 years ago. I immediately relapsed because the home life that I was returning to was a codependent, one-sided love affair, and that I did not share with the person, and they had their own problems that they were unwilling to acknowledge, and I was not, willing to deal with that. I didn't care enough about the other person to deal with it, so I was into my old stomping grounds, and I resumed my use even with greater vigor than before. And with that, I was a moderately successful criminal, so I was able to keep up with that for about 2 years before I was. I met a young woman who at the time was using heroin regularly, and we bonded over our mutual drug use and other things in our past that were strangely coincidental and brought us together. We had a friend in common also who had died from an opiate use disorder. And I don't know what happened to me. People that know me describe it as that my character changed 180 degrees. I didn't see it. I've been kind of a blunt, arrogant person, and I've had little regard for most people's feelings. But something in me changed when I saw this young mother, and I decided to calm down my behavior a little bit. Not all the way, because about a year after we started dating, um, I was arrested for burglarizing an abandoned house in South San Francisco. And once again, and then my girlfriend, now wife, became pregnant with my daughter, and so I was on the run from the law for a little while. They inevitably caught me. All the while, I was continuing to use methamphetamine and heroin with a abandoned. And I said to myself, if they want to catch me, they can get me. Well, they got me. So I was once again offered county drug treatment. For me, it was either 5 years in prison or, accepting a little drug treatment and some probation. So that's not much of a choice for those of you who don't know that scenario. Uh, I did my couple months in jail. I tried to make myself productive and, active in the occupational sector in the drug program. I then entered a drug program, Latino Commission, which was it, they meant well, but it was boring to the point of I could feel myself collapsing into lethargy. I'm an active person. I once again tried to get through it by dressing very plainly and acting as blandly as possible and trying to interact with nobody, which is not a good way to analyze your own behavior. It's a great way to get through things without being changed by them. But I wanted to be changed by this point, but I didn't know how, because I had no life skills and I had no people skills, and I didn't know. I wanted to change, but I didn't have the slightest idea how, and I wouldn't listen to anybody. so um, I, my wife, now wife, was almost about ready to give birth when I went to this program, and so I cut from the program against treatment indications a month into it, to go see my daughter being born, which, as you can probably imagine, that whole process was a disaster because I had broken my probation. I had I used while I was out, and I saw my daughter being born, but then I was like, uh, 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 um, I was on the run from the law, and I was called by my probation officer, who gave me a choice. He said, "Yeah, you can either come back and report to jail, or you can go to prison for 5 years." So that's, again, not much of a choice. Perhaps God was with me. The God I know to be indifferent was with me, and even though I tested dirty, my probation officer once again offered me the chance at a program. He said the program that I was in had filled up. That they fill up very quickly in California. And there was another program that was in East Palo Alto called Our Common Ground. Our Common Ground was where I finally decided to make a change and come alive to myself. Because I had been so beaten down, I realized that there was no way that I could be around my children and my now wife and be of any quality to them if I didn't change my behavior. Cognitive behavioral there is, once you accept it and can be a part of it, it's a great help. It's painful and it's annoying, but it is probably the only help that can be had for stimulant use disorder, because, as far as I know, the coke and meth are very, very different things. I've tried to overdose on meth by injecting an 8-ball of it. It's impossible. All you do is you pass out and then wake up like later, and then shrivel for 3 days, unable to move. I tried to commit suicide with amphetamine. It can't be done. I don't even know how to. If you bang up a gram of coke, you'll be blue, and but not the same with methamphetamine. It's a as far as where methamphetamine is not a central nervous system activator like coke is. Coke will make your heart stop, until it stops, and meth will not. It just gives you an all over body. Also, methamphetamine lasts for much longer. Yes, Aaron?
Yeah, methamphetamine definitely lasts for longer. It also does stimulate the central nervous system, but it may be that they work in a slightly different way. I actually haven't heard that you can't overdose from methamphetamine, or that one can't overdose. But I'm glad that you did not overdose from methamphetamine when when you tried it. And I'm glad you're here today to tell the tale, and that you found our common ground. I should, if I may, I want to mention that I've known Bryce now for 20 years, over 20 years now. And so, as always, I think you're a great storyteller, and I think that this is a really great glimpse for people who are maybe watching this recorded, or at least the three of us are here today. That just a really great glimpse into some of your experience with meth. I'm just mindful of the time here. This wraps up in a few minutes. And you actually hit some of the questions that I was going to ask you. Things that were totally unhelpful in terms of getting sober. You mentioned attack therapy.
Sublimely unhelpful. Yeah.
Carrying a stone from one place to another, not so helpful. But you mentioned that cognitive behavioral therapy was helpful for you, and also you didn't say the words contingency management, but contingency management is basically external consequences to actions that you're undertaking. And so the positive contingency of wanting to spend time with these people that you love, your wife and your children, is obviously something that was motivating to you, and the negative contingency of potentially facing a long prison sentence had a negative motivational effect as well. So I think that kind of like your experience, from my perspective, kind of is not contradicted by the medical evidence of what actually is helpful for people. I don't know if you wish that you had come around earlier, or if you just figured that it was the time in your life when it was going to happen naturally.
I couldn't have come around earlier. I was unequipped.
Yeah.
Mentally or psychologically or physically unequipped. Nor did I have a reason. I had no reason to quit. And I was going to say one more thing about now, from having been addicted to heroin as well, I found the availability of buprenorphine, of Suboxone, right, is what you're talking about, right? Suboxone was a great help at several times. I picked heroin several times, and I can tell you that it's very unpleasant to do so in jail without help. It's not life-threatening. Feels like it, but it's not. And there's no similar medication to assist with coming down off of methamphetamine. Basically, methamphetamine is not physically addictive. All you have to do is stop using the shit, and get over the boredom and depression and anhedonia that follow. There's no cure for that. It's called sitting it out and keeping active, and until you resume your enthusiasm for things. Yeah, I'm a little harsh on people who are incapable of that. I can't judge anybody else but myself, and I judge myself very harshly if I fail to try to power through those things, because nobody else. Let's face it. It's a cold world. Okay, nobody's about you doing anything. That's one of the reasons why I admire you, Aaron. You care about people genuinely, or else you wouldn't be a doctor in a harm reduction clinic. I can't express how much I respect you and appreciate you. You've also been helping my personal journey just by the advice you've given, not knowing the facts, me asking indirectly. I remember, and you've literally saved my life. from the advice you've given me, and the life of my now spouse, who is also grateful to you and your advice and help. I don't know if I've ever properly thanked you for that, but you know I'm with you in spirit, and I hope to see you soon in Baltimore, as I will be visiting there soon. 12-step uh, uh, recovery methods are helpful only for this reason: community. Having a community and having like-minded people, although it is a very mixed bag of inconsistent people, is a wonderful help and a great help in keeping on the path of recovery. Because otherwise, what's the point? People do drugs because they're dissatisfied with their lives, right?
Yeah.
Well, that's one way to keep from being dissatisfied with your life is to find meaning in it. Life has no meaning except what we give to it. You know, the meaning of life is to die eventually, and you know, you don't wait to be the case. You have to find out reasons to live.
I think that's a great ending point, Bryce. But I really thank you for making the time to share your experience today, and to save our the participants from having to look at more PowerPoint slides. So you served a dual purpose, and I agree. I'm so grateful to you for what you brought to my life as well. And which goes far beyond this 25 minutes together today. So thank you very much, Bryce.
Absolutely, my pleasure, and I'm honored to have been a part of it.
All right, talk to you later.
Ciao.
Bye-bye. Should we just wrap? Is that a wrap here?
I'm going to hand it over to Bridget, just in case anyone has any questions. I'm not sure if she received any in the chat.
I don't think there's any other attendees today, are there?
There's 16.
Oh, there's 16. Oh, good. I didn't see anyone else. Oh, what a relief. Here we are.
Yeah.
There. It didn't display on my screen. I don't know why. Oh, great. If I thought that we were lecturing to an empty room here. I would have made time for questions earlier. Is there any? I would love to hear if there's any participants who are here who had any questions.
So we did not have any questions written in, but if you do have any questions remaining for Dr. Greenblatt, please feel free to put them in the chat or in the Q&A section. Other than that, while you enter those questions, I am just going to go over some remaining housekeeping items. You will receive a survey that will pop up immediately following the WebEx event, and once you fill that out, we will send your certificate within 1 business week. I'll also be sending out the slides from Dr. Greenblatt as well as a reference that he mentioned from SAMHSA, and you will be receiving that email either later today or later this week. Other than that, we're so glad you could join us today, and I am going to turn it over to Julie, but once again, if you do have any questions, please feel free to put them into the chat now.
I just want to say thank you to Dr. Greenblatt again for presenting. Again, if you have any questions after today's, you can certainly feel free to call us. I know Bridget had put our contact information in previously, and you'll also receive our contact information in our email.
All right. Well, I wish everyone a pleasant rest of the afternoon.
Thank you so much, Dr. Greenblatt. Have a great day.
Thanks.
Thank you, everyone.